Let me welcome all of you in this very last day of the Congress, almost approaching the end of it. Your participation is very valuable. We work in the same clinic, in the same service, together with my colleagues. I would like to thank Özge Onur for helping us come and present in this Congress. I will speak about bipolar disorder. It's characterized by mania and hypomania, and it can lead to significant devastation. It's a chronic mental health disease and it's a social one. What we want to achieve is to enable the integration of the patient with the society, understand whether the patient is in remission or not. So these were the questions that we ask ourselves, and in the peripheral or in brain spine fluid, whether can we find anything which may help us with the treatment of the disease. Biomarkers were studied in this perspective, and some significant findings were found in the recent studies about the use of biomarkers. Some inflammatory markers are either significantly reduced or increased during the onset of the disease. Serum or plasma-like peripheric biomarkers, of course, would help us as they are less invasive and is readily available. Therefore, focus on peripheric biomarkers was there. With the increasing evidence, there were more and more studies, and inflammatory dysfunctions, neuroplasticity, oxidative stress, and mitochondrial function were shown to be associated with bipolar disease. And these were the candidate biomarkers which could be used. Of course, apart from all these immune markers and peripheric blood markers, we should also speak about the pro-inflammatory status of the disease. Autoimmune diseases were emphasized. In a study, it was said that neutrophils were decreasing in bipolar disease patients who were depressive. And there was another study, a cohort study, Guillain-Barré syndrome, Crohn's disease, and autoimmune hepatitis history was associated with a higher risk for bipolar disorder, and the incidence of bipolar disorder increased by 6 times in systemic lupus erythematosus patients, particularly female, and 30 times higher in multiple sclerosis patients. Looking at these biomarkers, of course, TNF-alpha, interleukin-6 and interleukin-18 were particularly found to be important. And the brain-derived neurotrophic factor was found, and together with neurotrophin-3, they said these could be modified in bipolar disease. The monocyte phagocytic factors were also increasing in bipolar diseases, and there were some hypotheses to explain why they are increasing. One opinion is that the disease itself triggers the hyperactivity of monocytes. Another hypothesis is that the monocytes are in hyperactive status, and it may be a key factor for bipolar disease development. Another hypothesis is that there is an underlying factor independent from the hyperactivity of these. Here, interleukin-2, IL-2 is important actually. It plays an important role. In IL-2 and interferon-14, their reduced production in bipolar patients, and there was no difference in the production of interleukin-4 in these patients again. These were the findings. Here, A-type TNF-alpha, TNF receptor 1 activity was not found actually. Here, the soluble patent was found to be effective, and the study focused on this. This soluble TNF receptor and TNF1 was found that there was an increase of the soluble receptor of TNF-R1. There were other studies about the cytokines recently, particularly soluble IL-2 receptor and IL-2 and the receptor interaction, and there was a signal modification related to this which plays an important role, which led to an increase in active T cells and clonal expansion. And also IL-1 receptor antagonist was found to be important. The pro-inflammatory effect of IL-1 was important, and the chemokines actually were studied. Osteoprotegerin and von Willebrand factor were found to be effective, and they were used as a sign of inflammation actually. The thiobarbiturate acid and C-reactive protein were also found to be meaningful. Regarding the IL-12 levels, there was a study by Kim et al. It was found to decrease significantly, statistically important decrease in IL-12, but there are of course some limitations of this study. Ortiz-Dominguez et al. Carried out another study. 10 manic patients and 33 healthy control patients. IL-1 beta, 2, 4 and TNF-alpha levels were compared with healthy controls. TNF-alpha IL-4 levels were high, IL-2 levels were found to be low. O'Brien et al. 12 manic, 21 healthy control group patients. IL-6, 8, 10 TNF-alpha soluble interleukin-6R levels were checked in manic patients. From interleukin-8, 6 TNF-alpha levels were found to be higher. Anti-inflammatory interleukin-10 and pro-inflammatory soluble IL-6R levels were found to be the same with the healthy control group. In this, actually, mitochondria is important. Mitochondrial function, dysfunction, and oxidative function impairment and oxidative stress, and the peripheric blood oxidative stress marker levels may be changed, and these support the pathophysiology, provide evidences that support the pathophysiology if there is a change in these. And oxidative damage of RNA was suggested as a new disease mechanism. These biomarkers, their clinical correlation is another question mark. It seems that in the neuroprocession of the disease, inflammation has a very important place as a major toxic player, and it is one of the mechanisms responsible for neuroprogression. This is what the findings in the studies show. These findings increase particularly during the mood episodes in bipolar patients. So the pro-inflammatory cytokines cannot freely permeate the blood-brain barrier under physiological conditions. They are large molecules, and some of the pathways that are included in the signaling period process of the central nervous system are the following on the slide: the blood-brain barrier leakage regions and active transportation and activation of other types of cells which are on the endothelial cells and the other cells that are on the cerebral vasculature, and the peripheric afferent nerve fibers. So the inflammation at the periphery, its impact on the brain, they said, could be higher than we think it is. There are some studies in this respect. And in the central nervous system, there is this framing. It is very important that the microglial cells play an important role because they play a progenitor role at the beginning, end of inflammation, or during the inflammation, the release of active cytokines and their connection with one another. From this perspective, a gene progression may be there, and macroglial cells are very important. In post-mortem studies, the microglial activation in bipolar disease were evidenced, but in vivo studies are lacking. For example, PET neuroimaging studies are not at the sufficient level right now. In one study, the pro-inflammatory cytokines in the brain spinal fluid of the patients were assessed. It was shown that IL-1 beta levels were increasing, and the pro-inflammatory status was not only in the periphery. And increased TNF-alpha levels were found to be associated with caspase and other problems. This neurodegenerative process, which is mediated by TNF-alpha, is associated with a volumetric decrease in the frontal lobe and hypoactivation. And here, an impairment in the inhibitor response could may be responsible, which means an endophenotype could be responsible for that. In these patients, the biomarkers are high and different. Is it the reason? Is it the outcome? Or is it an endophenotype indication for these patients? Interleukin 18 and 6 were not found to have a difference in the euthymic and control groups, and the interleukin 18 level in the bipolar group, they said there could be a positive association with momental memory, delayed remembering and learning. And interleukin 18, when we look at this, they say there could be a positive association with the neuropsychological test scores. In the anterior convolutor region, there is an increased transmembrane TNF-alpha protein level, and in the prefrontal cortex, the TNFR2 protein levels were shown to be reduced. These data reinforced the role of cytokines in bipolar disorder. So TNF-alpha receptor 2 was studied further. Myers et al. Carried out another study, 10 manic patients, 21 healthy patients who weren't treated for a week. The soluble interleukin 6 receptor, soluble interleukin 2 receptor levels were shown to be higher in manic patients compared to the control group. There was no difference statistically significant in terms of interleukin-6 levels. Sayi et al. Another study, manic and healthy patients, plasma-soluble interleukin-2 receptor levels were found to be higher in manic patients compared to the control group, and remission levels. And in terms of interleukin-6 receptor, there was no significant difference. So there was no correlation identified with the prolonged length of the disease, age, the onset age of the disease, and the number of manic periods in these patients. So there are similar results here. Bayi et al. Carried out another study. Healthy, euthymic, depressive patients were included in this study. Manic, hypomanic patients were included as well. Soluble interleukin-2R, 6R, CRP, STNF levels were compared and shown to be higher than the control group. Gene analysis were also always studied, and there were some remarkable outcomes from these studies. So here, ankyrin 3 and calcium channel, L-type alpha-1C subunits. Some findings about these were presented, but these were not very meaningful actually. Of course, these gene analyses are the ones we should always keep in mind. And Krupel-like factor 12 and BDNF were also studied. And there are some studies based on these, gene expression and proteomic analysis in the peripheral blood, but these studies haven't been repeated and had certain limitations, so they do not provide us a specific marker. Glucocorticoids, in studies related to them, medical comorbidities, HPA activation, these were studied, and they regulate other functions like the metabolism, not just immunity, and particularly in the hypophyse and the adrenal axon, the hypothalamic hypophyse adrenal axis HPA, there was an abnormal activation in bipolar patients. So the mood chapters may trigger stress reactions, and an abnormal activation in the HPA axis may occur, which may lead to maybe chronic inflammation. This was the idea, the question they had. Of course, after all these inflammatory processes, an anti-inflammatory system is very important for recovering of bipolar patients, and immune system appears to be a promising target. Neri et al. Carried out a study. One cyclooxygenase 2 inhibitor, celecoxib, was used in a double-blind randomized placebo-controlled study, and a complicated bipolar episode was conducted in this study. Although there were some significant findings, this process, whether it affects or not, whether it plays an important role or not, is still a question mark. Anti-inflammatories such as aspirin and other medications, their use is still being investigated in other studies. And the use of COX-2 inhibitors, there were another study about this, and it's still under discussion. The anti-inflammatory system, the SOD, an important enzyme, it was used. CAT and GPX enzymes were also used in the studies, and Frey et al. Carried out another study. This enzyme level, the catalysis level, was particularly found to be high low compared to the control group, and Tsai et al. Carried out another study with manic and healthy patients, and in 20 patients before and after treatment these enzymes were studied. GPX enzyme level was found to be lower in the disease group compared to the control group. Another study, Andrese et al., Kunz et al., multiple studies were carried out in this field, and the conclusion result is that the use of drugs, mood stabilizers, dietary habits and lifestyles have not been taken into account, and all of these can have an impact on oxidative stress. These are the limitations of the study. Such studies. Another study in our hospital, manic patients and healthy group patients were compared in a prospective study, antipsychotic therapy and EKT plus antipsychotic treatment. These were the two groups, combination and antipsychotic treatment group. Plasma TIS, TOS, OSI values were compared to the healthy control group, and the group which didn't receive EKT was found to be lower in terms of these values. Neuropeptides and its relationship association with gut flora were emphasized actually, and in these patients, particularly in the bipolar depression period, somatostatin was found to be at lower levels in bipolar patients, so this is statistically significant. And amyloid beta 42 protein was studied again, but there was no statistically significant difference. And AP4240 level, AP42 T-tau level, glutamine levels were checked, and the CSF serum albumin levels were also investigated, but there were no statistically significant difference. So the relationship with T-tau protein, although it cannot be explained, still there is an active investigation ongoing regarding its impact. The TRX enzyme, thioredoxin, they thought it could be an important indication. It's a small protein, and its serum plasma level could be an important indication of oxidative stress. Manic patients were included in a study, and the TRX levels were found to be lower than the control group in a prospective study before the treatment. So the TRX level before the treatment is another topic that we should be paying attention to. My last slide, discussion. Questions for discussion. Are these biomarker changes the cause or the result of the disease? And can biomarkers be used for predicting response to treatment or progression, or for diagnosing the disease? And immune endophenotypes, do they exist, or can they be used for predicting treatment and prognosis? And what is the relationship of cognitive impairment with inflammatory processes in the patient? So can we make a prediction about how fast the remission will be, how frequent